All right, so good evening, everyone, and welcome to the third class in the Renew Life After Education series. Tonight, we are joined by Nancy Hannon, one of the Cancer Center social workers, and she's going to be giving a presentation on sexuality and cancer. Go ahead to the next slide there, Nancy. So as the last 2 weeks, just some housekeeping information. So we just ask that you keep your microphone on mute during the presentation. There will be time at the end for questions, or if they come up as we're discussing here, you can go ahead and put them in the chat. If you come up with any questions after we finish, you can email them to the email on your screen there, renew@wrh.on.ca. This is the one that you've been getting all the communication from. So you can go ahead and reply to that email if you have any questions. And then at the end, you can ask them on camera, or we can do it via chat like we did before. And as always, I'll be sending the information via email in the coming weeks, as well as a feedback survey. I don't see anyone else in the waiting room, so we'll go ahead and get started. So this is Nancy, and she's going to take it away.
Hi, good evening, everyone. I hope you can hear me well. Yes, as Shannon said, I'm Nancy Hannon. I'm one of the social workers here at the cancer program. We have 5 in total, actually. I think I'm the one that's been here the longest, so I don't know if that's a good thing or a bad thing, but I have been here. I'm in my 16th year, supporting patients through their cancer journey. And I really feel strongly about this topic, and that I feel that it's quite important. And what I do find is that it's not a topic that is usually discussed, especially, with your oncologist and when you come in for appointments. So you may have some concerns yourself or your partner. And so I'm hoping, that I can share some information with you tonight, and that if you feel comfortable, you can certainly ask questions, or as Shannon said, you can write them in the email and or chat and send them to us. And I encourage everyone, and I'll repeat this probably a couple of times, but I do really encourage everyone to either self-refer to the Cancer Center for social work services if you really feel that you have some concerns about your sexual health. And you can certainly call the Cancer Center and put a message through to me directly, or you can speak to your medical team and they can put in a referral on your behalf. So let's get started. So why is this session so important? I think because, as I stated in my intro, it's just not a topic that's really talked about openly, and for various reasons, right? Some people just feel a bit uncomfortable or unsure of how to approach the topic. And what research has shown is, interestingly enough, that healthcare providers are willing to talk about sexual issues if, it's a big if the patient themselves brings it up. And then the same research shows that patients are waiting for healthcare providers to ask them. So the result is just silence. Nobody says anything. Even when you come into the Cancer Center, when you come to appointments with the doctors, I'm hoping that you're asked, it's called an ESAS questionnaire, and there's questions on there. Many of them are regarding symptoms that you might be having, which are very important. I'm not saying that they're not. And then there's a question about depression and another one about anxiety and overall well-being, but there isn't one with regards to sexuality. And sometimes what I've heard back from a lot of healthcare providers is that, it's not that they don't want to talk about the subject, but they're afraid to mention it in their appointments because they know they only have a restricted, time frame to meet with patients, right? And they're trying to get through their clinic and meet with as many patients as they can, right? As many people as are scheduled. So it's often a topic that they don't want to bring up because they're afraid. They sort of refer to it as, we don't want to open up Pandora's box and have a lot of questions or a lot of information that we just don't feel that we can adequately respond to appropriately in the time, the short amount of time that you're in the office. Because as most of you will know, when you've come in for your consults, it's booked for an hour, and then your follow-ups are generally about 15 minutes. So it's not a whole lot of time when you very likely have other issues like side effects or symptoms, or wanting to go over some test results with your healthcare provider. So what the research has found is that both the healthcare provider and the patient themselves or their family can be quite embarrassed and just not wanting to talk about it, or discuss that part of what they feel is their private life. So healthcare providers, believe it or not, one would think, as they're going through their extensive education, post-secondary education, and going through medical school, and then going through all the different courses that they have to take to be a specialist, you would sort of almost guess that they would get a lot of education about human sexuality. But they're not. They really are not provided with that. And so in some cases, they're afraid of being seen as lacking knowledge on the subject if they're asked. Some healthcare providers also believe that it's someone else's responsibility, right? Because their focus or their goal is on their treatment, whether it's systemic treatment with chemotherapy and immunotherapy, or whether it's radiation treatment. So for them, their primary goal is to cure the cancer, right? And to manage the treatments that you're having and manage the side effects. So in their mind, it sort of leaves all the other stuff that you might be trying to cope with and deal with to someone else, whoever that might be. So we're very fortunate in this cancer center to have 5 social workers that are able to really help many patients with psychosocial needs, such as the depression, anxiety, thoughts, feelings, helping them with practical issues that might come up. And but sexuality is just as important and should be included. Patients are often afraid that they will seem kind of stupid for asking questions, so it kind of holds them back from asking. They may not know who to ask because their healthcare team has never asked them if they have any concerns or questions. So because of that, they're thinking, well, do I even ask the doctor, or should I maybe go to my general practitioner? But then also in many cases, some people don't have a family doctor or a general practitioner. Many often just go to clinics and use clinics there, or they've never actually been, they haven't, they may have a general practitioner, but they haven't been in a year or more to see them. So they really don't know who they should be asking these questions to. And oftentimes patients will often feel awkward talking to the physician, especially if they're of the opposite sex, of a different age, whether they're older or younger, and or of a different culture, because they're not sure or comfortable enough, is this okay to talk about? They may not feel comfortable talking about it, so they're not going to initiate it. So these are all potential barriers that go on. The purpose of this presentation then is to provide valuable information so that all people, any gender, age, sexuality, or relationship status, have the right to ask questions about their sexuality and their sexual functioning, and to have those questions answered in a way that they understand and that makes sense to them. So we've tried to encourage, our medical team to, not sort of fluff off questions, but that, really take questions or comments that the patient might have, and then let them know that there is a service available and that there is a social worker that would be available to speak with them, either on the phone or in person. So today's discussion, I'm going to discuss intimacy, sexuality, and the factors that impact them. Talk about how cancer treatment can impact sexual function, and identify that the things that you can do to help yourself and help sort things through, and where you can find support. So the goals of this presentation is to outline 7 sexual health challenges that patients with cancer and their partners face. Identify and use at least 3 helpful suggestions to improve intimacy and sexual relationships, and discover the resources in the community to address sexual health concerns. So intimacy. Intimacy is the sharing of identity, mutual acceptance, closeness, reciprocal rapport, and heart-to-heart understanding. And is very closely linked to communication rather than actual sexual functioning. So it's a very important part of our self and our self-identity. And when a person feels intimately loved, nurtured, cared for, and supported, they're more likely to be healthier and happier. So one thing that I would encourage all of you to kind of think about just quietly in your own minds is, as you grew up, the family that you grew up in with, the supports that you received, and what you saw, between family members, or, a guardian, or whatever your family situation might be, what was shown to you, what was demonstrated, and what messages did you receive growing up, and even as a young adult. So sexuality is an important part of the total person. So it's just one aspect of us as human beings, but it is an important aspect. Sexual identity involves both feelings and behaviors, and it's an intimate form of communication that brings comfort. Sexuality is influenced by cultural beliefs, religious beliefs, stressors, any past experiences that you had, as a child growing up, and as a young adult in relation, and, starting out and learning, going on dates and being in intimate relationships, and just relationships overall. And intimacy, touch, self-esteem, emotional and social interactions, and communication help capture sexuality. So there's a lot encompassing in that. So the factors that influence sexuality, there's quite a few. So it can be, it's part of it is just who we are and the biology and the genetics that we're made up of. And our genetics of, coming from our parents and our grandparents, and knowing some of that. And for each person, that is very different, right? In terms of what we all experience can be very, very different. So you need to take that into consideration. Our developmental status, how old we are, what we've experienced up until that point. Our culture, if we come from, whatever culture you come from, has their own belief system, and the messages that you received, maybe from, parents, guardians, aunts, uncles, grandparents, religious leaders, any of that. Your ethnicity also is a huge factor. Experiences that you had, your religion or spirituality, and stereotypes. So there's many factors. Intimate relationships are based on trust and the ability to interact with others. It's modeled in our childhood homes, and we have early relationships. Our early relationships impact the way persons interact with others emotionally, intellectually, physically, and sexually. So it's all encompassing. And there's 4 types of intimacy. And it's interesting, as you know, as I talk about these 4, most people tend to, when they think of intimacy, they think of the physical part of being intimate, and you know, either hugging somebody, holding hands, physical touch, kissing, or actual intercourse. So many people, we think that, and in today's society, there is so much of that modeled within a lot of social media that's going on, the social media platforms that we are, that we involve ourselves in, movies, TV, all of that. So we tend to think of physical as the most, like that's sort of the first one that pops into our head in terms of types of intimacy. But the other 3 are just as important. And as you, again, think about your own experiences, you'll be able to kind of maybe make sense of some of those, and as you think of those relationships and experiences. So the first one is actually the biggest one, is emotional. So we tend to think of it as being physical, but it's actually the emotional type of intimacy that is the most important. And it's the level of trust, personal bonds, biochemical response, and social dimension that follows from physical closeness. The second type of intimacy is intellectual. So that's the exchange of thoughts, ideas, enjoying similarities and differences of opinions in an open and comfortable way. So, if you think of your own experiences, sometimes, if you've tried to initiate a conversation with a loved one or with your partner, and you're shut down automatically right away, because their experiences may be very different and they're not open to what you're saying, and then you don't feel heard, and you don't feel respected, right? So that can really impact that line of communication, and then it sort of closes the doors and shuts down, and a barrier is placed. The third type of intimacy is experiential. So it's the sharing of mutual activities. So if you're in a relationship, in a mutual, caring, respectful relationship, then, hopefully you can work out and talk about what feels comfortable for you. Where are your limits and boundaries, right? What do you feel comfortable doing? Maybe maybe based on your own family upbringing, ethnicity, culture, and religion, you may only have, you may have certain limits and boundaries in how intimate or how comfortable you feel. So it's important to be able to communicate that with your partner, so then you can then share and talk about what feels best for both of you, and how you want to start, and where you're going to, what maybe you might want to try and experiment on, but, when, and talk about when and how that may happen. So then you don't feel uncomfortable and forced into a situation that, where you just don't feel respected and heard. And then the last type of intimacy is the one that I mentioned at the beginning, where we tend to all sort of, our minds tend to all go to generally, is the physical type of intimacy, which includes touching, holding, hugging, kissing, rubbing someone's back, and sexual activity. So there's, various activities that can occur within that physical type of intimacy. And again, depending on our own personal experiences, growing up, what we were exposed to in our own family, and the messages we learned. Sometimes that can be very, very challenging and very difficult for some people. Or it can be a very warm, loving experience. So if we all go back to our grade school lessons, and usually in sex education, back in elementary school and in high school, you're separated. I think they're still doing it actually, where they have girls in one room, boys in another, and they both talk about things separately, but hardly ever together. So this is just like a basic picture of the male reproductive system. And so when someone is going through cancer, especially for a male in this particular instance, you can have a lot of, depending on, the type of cancer that you have or the type of treatment that you're having, you can have issues and concerns in a lot of these areas, either from surgery, could be, from surgery, or from the treatment itself, or from side effects. So there can be issues with, the bladder, the prostate, the testicles, the penis, the corpus cavernosum. So all of those areas can be impacted in some way, in a negative way, and it could take time for your body to heal and recover. And this is the anatomy of the vulva, and into the vagina. So for women, this is the anatomy of the vagina. So again, if you've, depending on the type of cancer you've had or you have, and the treatments and the side effects that you've had, it can also greatly affect and create a lot of issues for women as well. A lot of dryness and a lot of pain can sometimes be associated to the outside area as well as internally. So for the human sexual response cycle, there are several different theories. There's not a lot of research that has occurred over the years. So these are sort of the primary ones that have done some more in-depth type of research, and you're welcome to kind of read a little bit more on your own if you're so inclined. But one of the human sexual response cycles from Masters and Johnson, so this was research that was done back in the 1970s, and they researched and asked questions and did questionnaires and met with people and determined that there was four levels of in the human sexual response cycle. So the first phase was excitement, then there was a plateau, and then there's an orgasm, and then there's resolution at the end. And another research that was done by Helen Singer Kaplan, she, after her research, decided that there were 3 phases, not 4. So desire, excitement, and then orgasm. So in her research, it came out that both men and women experience these phases, although the timing is usually different. So both individuals, if you're in a male-female relationship, both people don't necessarily experience these 3 phases at the same time. So for example, it's unlikely that both partners will reach orgasm at the same time. The female response cycle focuses on thoughts and feelings, and then sexual arousal happens. And sexual satisfaction can be an orgasm, their own personal orgasm, or seeing one's partner enjoying the experience. So women tend to come from the thoughts and the feelings first, and then the physical reaction. So we're hoping that I belong to, there's a sexual health group through Cancer Care Ontario, and I'm a member of that, and we meet a few times a year. And we are made up of individuals from all the cancer centers across Ontario, across the province, and we share new information with each other, new research that may have come out, new programs that are being offered. So we share that information with each other. And, we're really, we're hoping that over the next few years that there's going to be more and more research done that, encompasses all the different types of relationships that people can have, intimate relationships, and that, we can learn more about it so that way we can pass that information on, that knowledge on, and be able to support cancer patients even more and in a much better way, more effective way. So disease sites, the disease site, so, everyone is diagnosed with a different type of disease, has a different type of treatment for that disease, and may experience a variety of side effects, right? So some people will have virtually no side effects. Some may have a moderate amount of side effects, and some individuals, unfortunately, experience almost every side effect that is possible. So each disease site has its own unique issues related to diagnosis, possible surgery, chemotherapy, or radiation treatments. And along with chemotherapy, many patients now are also getting immunotherapy. But there's one common fact. Doesn't matter what disease site you have or what your treatment involves. And surgery is definitely a form of treatment. But one common fact is that there will be a change in your sexual function to some degree. This can show itself in physical or emotional changes, or both. So because of that, if I go back to this slide, because there is most definitely going to be some sort of change, whether you might consider it a minor, moderate, or severe change in your sexual function, that's why it's important. That's why I feel it's really important that be shared with, the medical team, and that you get the supports that you feel that you need. So the physical side effects, there can be body image changes, bowel or urinary changes, decreased sexual desire or libido, fatigue, infertility, orgasmic changes and erectile dysfunction, pain. And pain. So yeah, so there's those seven physical side effects are the key ones. So the first one, I'm going to go through them in order and talk about each one. So the first one is body image changes. So for some individuals, they may lose a body part through surgery. So for women, for example, if you have breast cancer and you've had a mastectomy or a lumpectomy, you have lost a body part or a portion of your body part. Men could have, a penile cancer or a testicular cancer and have a body part removed because of it. And so that, you're dealing with not just the cancer diagnosis, but then you're also dealing with a major loss of a body part and how to cope and manage with that. And if it does involve, breasts or penis or, hysterectomy or whatever, those when you lose those body parts, it certainly does have an impact on how you feel as a person. And then it also impacts how you feel in a sexual intimate relationship. Decreased self-esteem can be attached to body image changes. weight loss or weight gain. Many times this can be caused by different medications, especially steroids. So they can be helpful for, for many things, but then they also have their own side effects and issues attached. Or you could have, depending on if you've had a surgery, for example, with bowels or something, and you need your bowels or your urinary tract, then you might need an ileostomy or an ostomy bag, and then you're eating, or you could have a feeding tube, and then you're eating differently as well, like you're not eating normal foods, you're having to eat foods through your tubes. And so then you may, experience some weight loss in that situation, and just you're trying to focus on making sure that you get all the nutrition that you need in order to stay well and healthy. So there's changes in your bodily functions can occur, removal of ovaries, testicle, ostomies, the onset of menopause, all kinds of issues. Infertility issues for those that are younger and, are still wanting to have a family or have children. And a lot of questions and concerns about, who am I now that I have this cancer diagnosis? And who am I as a person if I've lost or had to have body parts surgically removed? Who am I as a person? Am I a sexual person anymore? So a lot of people have, some very, a lot of thoughts and feelings around that, that may need to be shared with somebody on a professional level and help you feel supported. Number two, the bowel and urinary changes. So you can some people experience bowel or bladder incontinence. You can have, through surgeries, you can get catheters, nephrostomy tubes, drains, colostomies, ileostomies, I can't even speak tonight, urostomies. So suddenly your body is very different, and you've got all these, you may have extra, tubes and things hanging from your body. And that can be, you're trying to get accustomed to that and all the changes that are happening to your body. But at the same time, if you are involved in a intimate or sexual relationship with someone, it can be really uncomfortable, and you may not know exactly how to initiate conversations and how to talk about your thoughts and feelings, and get feedback from your partner as well, in terms of what they're thinking and feeling, right? They may be very scared, and how do I touch you, and I don't want to hurt you, and I don't want to cause pain. So how can we kind of work through this together and sort things through? Other bowel and urinary changes include diarrhea, constipation, and in some cases, odors. Number three, the decreased sexual desire or libido. So this can be caused from chemotherapy, certain chemotherapies, radiation therapy, surgery, hormonal treatments, and different medications. For a lot of people, they just feel very fatigued. I mean, after you've gone through and or experiencing treatments, it's just exhausting, right? It's exhausting having to keep track of all of these appointments, get to your appointments, deal with all the medications, the changes in medications that, physicians may make as they're trying to help you and sort through things. Just trying to keep track of appointments, as they might be, you may think you've got it all, and then they call you and say, oh no, but we have to change this appointment, or we now need you to come and do an extra lab, or we need you now to do like a 24-hour urine samples. So there's all kinds of things, right? All those things that are going on in your regular life, and trying to keep things sorted through. So the fatigue is not just from, the treatment itself. It can be from all kinds of factors that are going on in your life. Pain is definitely one that impacts sexual desire and libido. When you're really uncomfortable and you're having a lot of pain and discomfort, it's very hard to imagine yourself in an intimate relationship, or even wanting to be touched sometimes. Nausea and vomiting can also decrease sexual desire, and other medications such as antidepressants, blood pressure medications, and pain medications. So it's important to look at all of those factors to kind of determine, next steps and how to manage and handle your sexual health issues. Depression, anxiety, and stress can create decreased sexual desire. As I mentioned before, I think body image changes, infertility issues, fear of restarting sexual activity. If you were in a relationship, or you are in a relationship, and if you had say some type of surgery, or you were impacted a great deal by your treatments, you may feel very uncomfortable and not be very worried about, well, I would like to start having sexual intercourse again, but I'm very concerned because I don't know what it's going to feel like, or how my partner's going to feel, and am I going to be in pain? I don't want any more pain than what I've been dealing with. And this has a huge impact on relationships and changes in the relationships. And what we find often is that there's an increase in conflicts that occur. Fatigue is one of the other factors. So fatigue can be caused by depression, a change in lifestyle, medication side effects, pain, anti-nausea medications, and psychiatric medications. Stress from finances, if you've had to stop work, you might be getting some sort of income, but it's reduced, significantly from what your lifestyle was used to. You could have some debt. You're unable to pay bills. All of those kinds of worries are on your mind. Relationship issues, and just dealing with an overall disability. And surgery and chemo and radiation therapies can all be related to fatigue as well. Number 5, infertility issues. So we really encourage, and our oncologists have, again, depending on your age and the type of diagnosis that you have and the treatment that you're going to be getting, but they'll often, they should be having discussions with young people around preserving sperm or ova. And there's sperm banks and ova banks where your own sperm and ova can be banked and saved, so that once your treatments are done, then, and if you're given sort of a green light, so to speak, you can move forward and begin to have children if that's what you desire. Decreased sex hormones can cause infertility issues. Hormonal therapies, the inability to have a child, short-term or long-term. Sometimes I work with, I've worked with young moms and their partners, where they may have had one child, but they, dreamed and talked about having, several children, maybe 3 or 4 children. But now, because of their disease and their diagnosis and treatments, there is that strong possibility that they may not be able to, have the family that they once thought of, right? So it certainly has an impact on, your hopes and dreams and wishes that you had as a couple. And it changes how one perceives gender roles. Orgasmic changes in women. So depending on the type of treatment you've had, or again, the disease and the diagnosis, vaginal dryness can occur, vulva irritation. So going back to that earlier picture of the female anatomy, painful intercourse, just a lack of desire, decreased arousal, injury to pelvic nerves, decreased clitoral sensitivity, decreased elasticity of the vagina, increased sensitivity to touch, and depression. And then for men can often experience erectile dysfunction or something that's called retrograde ejaculation. And that's ejaculation is the ejection of semen out of the urethra, which is the passageway inside the penis, so when a man has an orgasm. So under normal circumstances, ejaculation propels the semen forward through a man's urethra and out of the tip of the penis. This is because there's a tiny sphincter, which is a circular muscle at the entrance to the bladder. It shuts the opening to the bladder and prevents the semen from entering. But with a retrograde ejaculation is when the semen travels backwards into the bladder. So that sphincter doesn't shut. It stays open and it sends it back in the other direction. Or sorry, it shuts the opening and sends it back. My apologies. And men can also get injury to pelvic nerves and also struggle with depression. And for both, there's disruption of the sexual response cycle, as we said again, or as I mentioned earlier. So there can be everybody generally experiences something, but it's to various degrees. And the last one was pain. The last factor was pain. So when you focus on the pain issues, if the pain issues are not being managed well, we're very fortunate in this country that, there are many different pain medications available. And so the physicians, like your family physician or your oncologist, has a license to prescribe certain pain medications. If those general medications are not helpful and you're still finding that you're having significant pain, then we do have here in our center, there is a pain and symptom management. It's a palliative pain and symptom management, but sometimes the doctors, the oncologists will refer people to our clinic because they don't have the license to prescribe the same type of medication that our palliative physicians do. So, in 2024 in Canada, we should be able, might have to tweak some medications and stuff sometimes, but there, are good outcomes in terms of managing pain so that you can have quality of life. Painful intercourse. So again, you can be very worried and concerned or anxious about having intercourse or any type of sexual touching or anything because of pain. Side effects of pain medications can decrease sexual response cycle. So again, it can be a bit frustrating because you're taking medication to help with one issue, but then it's causing something else, causing another issue. So that can be very frustrating to deal with. Skin sensitivity may increase or decrease, which causes a lot of discomfort. So then arousal does not happen. So treating sexual dysfunction, it's very important to educate yourself on changes in sexual functioning. So we do have available to us in the Cancer Center, there's pamphlets from the Canadian Cancer Society called Sexuality and Cancer. We have a booklet, so that can be made available, and you can certainly, we have different pamphlets around the Cancer Center. If you don't find it, then please let us know, and we'll definitely get you one. You can speak to your care team about concerns and changes in your sexual functioning. You can talk to your partner about your feelings of loss, fear, and changes in your relationship since the cancer diagnosis. And I encourage you to get counseling on an individual basis or with your partner for emotional concerns. And being open to learning new ways to communicate sexually with your partner. And in some cases, it's just learning different ways on how to communicate effectively so that both of you feel that you've been heard and listened to. So new ways to communicate, reduce the fear of sex, and you can enjoy non-sexual touch like cuddling, hand holding, kissing, embracing. Start sensual touch and desire. Sorry, if you start sensual touch, then desire and excitement will follow. And following your post-treatment care is very important. So you may you may be given directions or instructions on using dilators for women, or going to a physiotherapist for pelvic floor exercises. That can be for men or women, and or making sure that you're following through with the medications that you've been prescribed and taking them as prescribed. And overall, just learning new techniques. So that's how a referral to social work can assist you. So suggestions for female sexual dysfunction: consult with your physician if there's something that you're concerned and worried about with regards to your sexual health. The use of vaginal moisturizers, and we encourage ones that have a more natural ingredients in them. So like coconut oil, Repagan, which is a vaginal hormone-free suppository. Use of vaginal lubricants, and there's more information coming up on in some future slides. Vaginal dilators, being prescribed estrogen if it's not contraindicated with other medication that you're taking or treatments that you're having. So that can come as a cream. And physiotherapy for pelvic floor exercises, which I mentioned. So there's 2 local ones that we encourage people to use. You may need a prescription. So if you do have a plan, a private benefit plan, like maybe perhaps through like Sun Life or Green Shield or something, they may require that you get a prescription for physiotherapy for the pelvic floor exercises. And then these are the 2 that we recommend, or that we've heard some very good feedback from: the Burton Physiotherapy and Chiropractic on Tecumseh Road East, and LifeMark, Dougal and Olette. There are also clitoral stimulators, dildos, vibrators, masturbation, sex toys, fantasy, and erotica. And I do believe that Shannon said these slides will be sent to you, so you don't have to memorize some of this information. I put together a chart of vaginal lubricants that are available in Canada. So they're water-based lubricants. And so the different names of them are on the left side, the manufacturer, and then they're usually in a gel or a liquid form. And they're water-based, so they're very safe. And then there's silicone-based lubricants as well. And so the names of these ones with the manufacturer, and then the form again is in a gel or a liquid form. So how do cancer treatments affect your vagina for women? Surgery and radiation treatment to the pelvic area can cause a great deal of scar tissue to form in the vagina, and it results in the tissue becoming less elastic and dry. And so that's what often causes a significant amount of discomfort and pain. So this may lead to potential shrinkage of the vagina or the vaginal opening. And if this happens, you may find it difficult to dilate your vagina for intercourse and pelvic exams. So oftentimes the physicians will prescribe dilators. And when you get the dilators, they come in various sizes. So what they recommend is that you start with the smallest one and use that several times, and then work your way up to the sizes so that it feels more comfortable. So then if you are to have sexual intercourse with a man, then having, the penis enter the vagina is, it becomes more comfortable, because the dilators will stretch the skin and stretch that area. And vaginal dilators can be used to prevent, vaginal dilators can be used to prevent or manage this side effect. So a vaginal dilator is a smooth plastic, silicone, or rubber cylinder, similar in shape to a tampon. The dilator works by stretching the tissue of the vagina, helping to make intercourse more comfortable and improve the ease of pelvic exams performed by doctors after cancer treatment. Dilators can be purchased on their own or as a set. Some women use a vibrator, a dildo, or their fingers instead of a vaginal dilator. Most vaginas are 3 to 5 inches in length, so fingers alone may not be enough. Please do not use candles, which may contain lead, or food items, as they cannot be properly cleaned. And then you'll be creating a whole other issue with very possibly an infection. So vaginal dilators are to be used once your radiation treatments are finished and the vaginal irritation has decreased. So typically that takes between 2 and 4 weeks after your last radiation treatment. Women who have vaginismus may also benefit from using vaginal dilators. Vaginismus is an involuntary contraction or reflex muscle tightening of the pelvic floor muscles that generally occur when an attempt is made to insert an object. So many women will recognize this as, if they've gone to the doctors and they've had a pap test done, and the tool that they use to put in the vagina in order to collect the sample from your cervix, oftentimes you tend to clench your buttocks and your legs, and then your buttocks comes up off the table. That's your pelvic muscles tightening and reacting to something, an object entering your body. So it could be a tampon, penis, the speculum, which is used for the pap test, into the vagina. Vaginal dilators can also be effective tools in helping to stop the contractions. So once your vagina is not as irritated, then it's easier to insert those tools or items, and then it helps to kind of stretch and soften up that area. So it makes intercourse or pelvic exams much more comfortable. So suggestions for male sexual dysfunction: consult with your physician regarding any sexual dysfunction that you might be having. And then there could be a possibility of, there's different medications that can be used. There's Cialis, for example. There's injectables. Men can also use penile vacuum pumps. They can also use pelvic floor exercises to assist with strengthening the bladder, working on eliminating or decreasing urinary incontinence, bowel incontinence, and sexual function. So again, I've listed it's the same 2 physiotherapy offices in Windsor. There's also penile implants, and they come in both soft and firm. There's masturbation, erotica or fantasy, sex toys, and strap-on dildos. So ostomy information and resources, because this is having an ostomy or an ileostomy, can also be something that certainly impacts sexual intimacy. So again, communication is one of the biggest keys that we talk about. So if you have a current partner, recognize that both you and your partner need time to adjust, right? Adjust to all the changes that have happened, and discuss how you both feel. That's very important. So getting back to almost the beginning of the presentation where I talked about communication is one of the key things. So having comfort levels with each other, being able to talk about certain things, and within your relationship, and then beginning to resume sexual activity. And if you're struggling in terms of how do I begin this conversation, or then that's how social work can also assist, right? We can meet with you privately and individually, and talk to you about your own personal situation, and then bring your partner in as well. And also there are sex therapists in the community that we can then refer you to if necessary. If you have, so that's for if you have a current partner. If you have a new partner, consider the timing of when you want to disclose to your new partner that you have an ostomy or an ileostomy, and educate your new partner on your disease diagnosis, and whether you had, and then the surgery that you had to have to get the ostomy and the ileostomy, so that it clears up a lot of misconceptions, and it will help your partner to understand what you've gone through, what you've experienced, and hopefully they can then in turn be, very respectful, very kind, and very supportive. So intimacy tips: show, if you do have an ostomy or an ileostomy, show your partner your stoma or the pouching system. Cuddle and touch. Focus on your feelings initially rather than on the actual pouch itself. Cover your pouch with special coverings, or you can wear crotchless underwear or panties if you like. Empty your pouch or apply a new pouch, and you can use a closed end pouch or a stoma cap as appropriate. You can also use deodorizing drops or spray, and try different sexual positions that work best. You might have to try different positions to see what feels comfortable for you and what feels comfortable for your partner. Ask your physician if Imodium, Beano, or Gas-X can be taken before you plan on having, not that it has to be planned like you're going to a doctor's appointment, but you want to make sure that you're not causing further discomfort for yourself or your partner if you take some of these medications before having intercourse. And you may want to just try, bathing or showering together and exploring each other's body again, or for the first time. And what we always recommend is to never insert anything into the stoma itself. So here are just some pictures of products that are available for ostomy pouch deodorizers. And these ones are available. And you can get them online and delivered to your home, or you can purchase them in a store. And here are some intimate clothing that is available for men and women. So they've come out with, and they've designed some really nice, everyday clothing and intimacy clothing that can cover the ostomy or the ileostomy, so that it's not as visible, and, it may be less embarrassing or awkward. And there's some further pictures of some well-designed intimacy clothing and everyday. So with regards to sexual positions, the goal is to prevent trauma and pressure to your abdomen. So there's several different sexual positions you can use. You can spoon, stand and lean on the edge of the bed, have intercourse from behind. And then there's missionary style, froggy style, reverse cow, brace position, and or standing oral sex. And these are some online resources that are available. So there's cancer.ca, cancer.gov is, and youngadultcancer.ca are Canadian. And there's the specific one for prostate group, wpcsg.com. And there is also a local prostate group here in Windsor. And they meet generally, I believe, at the local hospice on the East End on Empress near Tecumseh. So they use that area as their meeting groups. I think they meet once a month. It's a group of men and they all meet together, and wives or partners are welcome to attend the group with them. And then I've just got a list of online reputable sex shops. So you can certainly go online, peruse the websites, and if you want to or choose to order something, it will be delivered to you in, in a non-identifiable package. So it's all very discreet. So just to review, I've outlined 7 sexual health challenges that patients with cancer and their partners face. I've identified at least 3 helpful suggestions to improve intimacy in sexual relationships, and shared with you several resources in the community that address sexual health concerns. So I don't know if anyone has any questions at this point, or if any questions have come through on the chat. And again, I know some, I totally understand if some people feel a little bit uncomfortable and may not want to post a question or ask a question, but I do encourage you, as I stated at the beginning, I really do encourage you to either contact the Cancer Center and request a social work referral. You can certainly do that on your own, or you can certainly go through your medical team and they can forward a referral. And that will come to me, and then we can book something that is convenient for you. What I try to do with many of my patients is that I don't like to have to make separate appointments. I don't want you to have to come back to the Cancer Center just for me. But if you're coming in to meet with your doctor, or you're coming in for lab work, or you're coming in for some other appointment, then we can try to coordinate an appointment on that very same day. I just want to say thank you to everybody.
Well, there is one question in the chat.
Okay.
So would you say it's a normal thing to see the gyno to get some answers and help with some of these issues?
Oh, definitely. Yeah. Gynecologists should be very, very informed and have lots of good information. And then, depending on what your particular issues or concerns are, hopefully they can be addressed and answered by the gynecologist and the gynecologist. You can also ask for some written information or websites or something that you can then, go back and kind of review on your own time. And then And then I would encourage you then to, if you needed to then make a follow-up appointment with the gynecologist if you have, any outstanding questions or, that are particular to you and your circumstance, just to make sure that you feel comfortable and that all your information and your questions have been answered. And then if there's something that is outside of the gynecologist's sort of field of expertise, then they can then help you to make a referral to someone or, make some recommendations for you to speak to somebody in the community. I hope that answered the question.
Yeah, she said thank you.
Okay, wonderful. Yeah, so speaking to, I mean, if you feel that you have an excellent rapport or relationship with your family doctor, the oncologist, a gynecologist, whoever it is that you feel like, you have a nurse practitioner in the community, there's more and more of the health team medical centers opening up. And so they have nurse practitioners, they have social workers there as well. So if you've got those kind of connections already and that support team available to you, if there's somebody in particular that you feel more comfortable speaking to, that's who I encourage you. There's no right or wrong person. It's, making sure that you feel comfortable speaking about, the concerns and the issues that you have. And so if you already have somebody that you feel like, I encourage you to have that conversation. It doesn't necessarily have to be here at the cancer center.
Great. Thank you, Nancy.
All right. Thank you, everyone.
Not seeing any more questions in the chat, but again, you'll get an email from me, and if anything comes up, you can go ahead and email that to me and I will pass it along to Nancy, or like she said, you can make yourself a referral and make an appointment with her. So I hope everybody has a good night, and I hope everyone joins us next week. We're going to be having a discussion on exercise after cancer with Dr. Scott Adams. So yeah, hoping everyone stays safe from this weather. I know some storms came through, but have a good night, everyone.
Good night. Thank you.